So I'm going to speak about the lip beautification without too much about technicalities, but much more about like the how to think about it, what would be the perfect size, and what in case that you don't have a beautiful result. So what would be the common issues when injected with hyaluronic acid fillers. So speaking about the lips, okay, we saw some devil lips on Instagram as well, and I definitely doubt these are really real, but maybe a Photoshop. But people thinking already about it is also a clue whether we're gonna see it one day. So we saw that in Africa they filled the lips with clay or wood. But of course, today we're not going to fill them with clay, wood, silicone, some artificial materials. We're going to fill it with hyaluronic fillers. And the question about lip metrics is how, proportionate they should be. If we're speaking about the Caucasian whites, like me, right? The proportion from the upper lip to the lower lip would be 1 to 1.6. This is the golden ratio. But if we look at some other very, very famous actors and people, we can see here Angelina Jolie that actually is having the 1 of the upper lip to 2 of the lower lip, meaning that her lower lip is 2 times bigger than her upper lip. And then if we actually look at Brad Pitt here, okay, so if we look here, so we see that actually his upper lip is 3 times smaller than his lower lip. Okay, so this is good for men, completely good and nice. Fortunately, that is not something that happens very often. Here we see one of the cases that Dr. Ala Aref from Renew Clinic Saudi Arabia actually showed, and we can see how the necrosis was doing. And we had on the third picture we actually see that the part of the lower lip actually completely fell off, and when we had the healing of the wound we see that we have a big damage. So this is something that we can definitely see if we had the one side of the inferior labial artery. And of course it can happen to all of us. The thing is, we have to check on the patient, we have to call on the patient tomorrow or 2 days after to see how he's doing, she of course, and then if there are any problems, react very quickly. So if we want to create to know what is happening and just to be sure that we can react very quickly. So on this side we have how to identify an occlusion of necrosis. So usually the patient feels the pain, a lot of pain, but of course if we had a lot of anesthetic, the pain will probably not be seen. Then we have the prolonged bleaching, discoloration, and it can be cool to touch. Of course the patient is gonna usually feel again the pain after it goes to home, and if we see those, we should definitely stop the treatment. And in some scientific articles I have read, they told okay, do a massage, but there's always the question, should I do the massage, because that hyaluronic particle can actually travel in some other side and maybe create a problem. Then of course the heat, because that will create the vasodilation of the vessels, and of course you have to do a hyaluronidase. Hyaluronidase is a must, definitely, and of course there are different ones depending on the country, or of course the continent. If we're speaking about the USA, we have the ones that are ovine, bovine, or even recombinant human hyaluronidase. And the thing that is really interesting is it's always in a solution. So it's always patients that are coming with excess of the HA filler and nodules, we have to use the hyaluronidase, and we're going to remove that. This is the patient I received, and it was treated by another actually very famous doctor. And what he did is he applied a lot of hyaluronic acid submucous. So when she came, I saw a lot of product actually very superficially to the mucosa, and you could actually see a lot of filler, just like, you know, when you see the frog going like this. So that was a balloon actually of hyaluronic fillers. I applied the hyaluronidase there, and after 15 minutes of massage, it completely dissolved. Another patient came to me from Dubai, and she was treated with very high quality actually filler, but not the one that is supposed to be injected into the lip. At first, I didn't know what is there, you know, with the red arrows. It was like very hard to the pressure, and it didn't move. So I thought maybe it wasn't a hyaluronic filler at all. So what I did, I took a needle and I pinched that, you know, white ball, and the hyaluronic filler completely, you know, went out, and I saw it actually is hyaluronic filler. And with the application of the hyaluronidase, we got the result here. So it's really nice after that. So you have to be actually sure. And then something that we actually don't think a lot when we are injecting the lips is the herpes labialis, or the oral herpes. And that is because the virus actually causes painful sores on the lips, but of course other parts of the body, and specifically oral area. So I should, like, but sometimes I also forget, is to ask a patient, do you often have cold sores? So if a patient has a lot of cold sores in the previous period, then we have to be sure to prevent the outrage of that herpes. So how a patient could recognize whether they have a herpes labialis? Because before the outrage, they will see they will feel the tingling and itching. Then, of course, they will see the blisters, and those blisters will pop up, and then the oozing and crusting will appear. But of course, we should prevent that. So how should we prevent that? We should, when we ask a patient whether they have something like that, to give them aciclovir or valacyclovir with oral route, because that is effective in preventing the recurrent herpes labialis if taken prior to the onset of any symptoms or exposure to any triggers. But of course, sometimes we